when the truth is that we did the worst of any industrialized country, and that we had developed the strategies which were successful in other countries and were exported, and then we threw away those strategies and didn't follow them. After the first wave of disinformation and politicization, which happened really in the early summer of 2020, and then definitely into the fall of 2020, COVID became a red state catastrophe. Well over 1 million people, we're up to 1.5 million Americans died, most of them red state people who didn't want to follow those rules. Let's put it where it belongs. It was a Republican Party, Donald Trump failure that killed many hundreds of thousands of their followers. And that's just the fact.
Welcome to the East Anchorage Book Club. I'm your host, Andrew Gray. The purpose of this podcast is to tell the stories of Alaskans of interest and importance. Today, our guest is writer and former Anchorage Assembly member, Charles Wohlforth. He is the author of more than 10 books and numerous articles about science and the environment, politics and history, medicine, travel, and as told to biographies like, most famously for listeners of this podcast, To Russia with Love, with Alaska hero Vic Fischer. The Whale and the Supercomputer won the LA Times Book Prize in 2004. Today, we are talking about his series of articles from the ADN published in 2016 and 2017 about problems with Alaska's healthcare system. We are also discussing his 2022 book that he co-wrote with Dr. David Nash, How COVID Crashed the System, a guide to fixing American healthcare. Charles Wohlforth, welcome to the podcast.
Thank you for having me.
You're Alaska famous. Most people who read the ADN or have followed politics in Anchorage know who you are. But tell us a little bit about your early life.
Sure. Yeah. My family moved to Alaska in 1966. I was 3 years old. My parents were very involved in those early years of statehood. My dad was involved in state government, and my mom in a lot of local stuff in Anchorage. And I grew up thinking of public service as an obligation and part of life, and also wanted to be a writer. So I went away to college, came back, and went to work at the Homer News, then worked at the Anchorage Daily News, got elected to the Anchorage Assembly when I was 29 years old and served there for 2 terms, and really never looked back in terms of my career. I've been a writer ever since and involved in public policy in one way or another ever since. Then in 2015 to 2019, I wrote a column for the Anchorage Daily News, which I focused on a lot of issues, including public policy regarding healthcare. And in 2019, I moved to New Jersey because I'd fallen in love and got married here, and have continued working on healthcare and writing science policy, and also writing still a lot of stuff about Alaska and working with Alaska public officials.
Did you grow up in Sand Lake?
No, I grew up primarily in Turnagain, just in the classic Turnagain area and over by Forest Park Drive. And my folks moved out to the Sand Lake area after I had left home. So you might be thinking of that.
You're in New Jersey now. I think folks will know that you're still writing a lot for ADN. You're still following Alaska. Tell us about having spent your life in Alaska and now living in New Jersey. What's that experience like, just observing Alaska from so far away?
I've stayed super involved with Alaska because I still have a place on Katchimak Bay and spend the summers there. So I'm a snowbird in some respects. Yeah, I moved from the least densely populated state to the most densely populated state, of the lowest tax state to the highest tax state, from a red state to a blue state. I think I moved to culturally about as far as I could possibly do. And I actually really love it here. We live in a beautiful area of horse farms and hills and cycling and really nice seasons, and quality of life here is extraordinary. And a lot of things that have weighed down on Anchorage are not a problem here. We've got amazing public facilities. The schools are superb, great public transit, really no crime, no homelessness. It's just, when I go back to Anchorage, I'm sometimes shocked by the way some of these social problems have crept up and become so deeply ingrained in my hometown, the place I love. I do miss a lot about the outdoors. I miss definitely winter sports and just the wilderness qualities of Alaska a great deal. But I just have to say that sort of in terms of the public systems, how they work here, they just work better. The problems get solved here, and they don't seem to be getting solved very well in Anchorage.
I think that's an interesting perspective. The New Yorker has done some stories on Camden, New Jersey, and just issues with the bigger cities and the hospitals, and specifically speaking of healthcare. And I think for somebody who's never lived in New Jersey and hasn't spent much time there, I'm surprised by your description of New Jersey.
Yeah, there's a positive on Alaska's side is Alaska has less income inequality than any other state. New Jersey, tremendous income inequality and self-segregation racially. But in terms of healthcare, if you look at the Leapfrog Foundation, which rates all the hospitals in the country by grade, we have access here to A-grade hospitals everywhere. And the lowest hospitals here are similar to the mid-range hospitals in Alaska. So there's a certain aspect of just having a large number of people and the size of an economy, I think that has allowed some things to excel here that don't in Alaska.
Since you mentioned the self-segregation, you wrote a column last summer about the efforts by the Anchorage Assembly to get rid of zoning, and that there had been some argument from the Assembly that zoning was a racist way of deciding where people lived. I reread your column yesterday. I'll put a link in the show notes for people to take a look at. You acknowledge that there was racism in Anchorage, for sure, and there still is. I think that there were some folks who definitely took offense to your column that zoning in Anchorage, from your perspective, happened so late that there were certain federal protections that would have prevented the zoning from being for racial reasons. I did read the response from Celeste Hodge-Groden. She wrote a response to your article, and she's the president of the Alaska Black Caucus, saying that she felt that it minimized some of the racial disparities in housing in Anchorage. I think you both wrote very careful columns. My pushback would be that I think that when you say that certain areas are for single-family homes and that other areas are not for single-family homes, and it appears that places that are not for single-family homes tend to have a lot more minorities and lower-income folks living, that it's a chicken or egg question for me, that in some ways having zoning, even if it didn't have racism as its roots, the result is perhaps encouraging more segregation in our city than we would otherwise have. And I don't know if you can respond to that.
Yeah, I first of all, I really respect Celeste, and I thought her column was right on. She had a lot of good stuff in it. But it's setting up a straw man to say that I was saying there was never any racism in Anchorage, or that there were never any racial covenants. Fact is, though, that the vast majority of Anchorage was built, and the vast majority of zoning was put into place when those things were not only illegal, but they were publicly reviled by everyone. And although there are certainly racists still in Anchorage, that's not a reason to get rid of the zoning. The point you raise about like more minorities live in less expensive housing, therefore all housing should be the same, to me begs the case of like, why should minorities be of lower income? In other parts of the country, in Alaska, very sadly, is way far behind on this. There are more minorities are in more different economic stratum. And when African American people become well off, they want to live in single family houses too. So the idea that every area should allow every kind of housing, I just don't think responds to the way people want to live. And for the, progressives sort of think we want to get rid of magnet schools because sometimes more white kids get into magnet schools because they test better. So we're going to lower all schools so that everybody can get every school. Or we want to get rid of like the nice neighborhoods, because that is something that a lot of minority folks that I know just sort of reject. And as we look at this last presidential election, I think we need to start thinking about the fact that the progressive bubble in some of these solutions that are suggested really do not reflect how most people feel in every racial group in America. So, my solution to economic inequality is to create more economic equality, which means pre-K, universal pre-K for kids in every community. It means making sure the schools are better in communities of low economic opportunity. It means do all of these things that you do from the ground up so you create actual equality of opportunity. To me, it doesn't mean saying, oh, we're not going to have neighborhoods with single-family zoning because we failed in creating economic equality, and that's the only way to get racial integration. The other thing about Anchorage is it's an extraordinarily integrated city. It may not be a super diverse city in that it's still majority white compared to New York City, which doesn't have a majority population. But where people live is extraordinarily integrated in terms of whites have not fled. We have many schools that have a high degree of integration. You don't have a robust private school system, so everyone participates in the public schools. And as I mentioned before, you have a great deal of economic equality. I feel like these assembly members, like Chris Constance, was kept harping on the need to get rid of these zoning things to redress the racial discrimination of the past. It's just importing a history. That's not our history in Alaska. There are some pretty significant and serious inequalities in terms of income. If you look at income of whites in Alaska, it's 50% above average white people in the rest of the country. Blacks like 20%, Pacific Islanders less than the rest of the country. So from that point of view, if I go into a restaurant here in New Jersey, I'm able to see people of all races. In Anchorage, you go into a fine restaurant and you only see white people because there is more economic inequality matched with race in Anchorage. But I don't think that has anything to do with zoning.
My pushback would be that removing single-family zoning does not mean that we're suddenly going to be building a lot of affordable, low-cost apartments on the hillside. The bottom line is that developers are going to put things where they pencil out and where they make the most sense. The idea that we have to protect our single-family homes by zoning, because if we don't, we're suddenly going to put a lot of low-cost housing and people will be using the bus. And honestly, we have seen columns, we have seen letters to the editors where people say that the idea that they would have people who would be reliant on the bus in their community wouldn't fit the character of their community. I'm just not sure that we need zoning to do what the free market should be doing itself. And it really does feel like that the zoning is enforcing poor people should live here, close to freeways, close to bus stops. And we need zoning to make sure that stays the case. And these quieter communities that are a little further away from city center, we're going to protect those as single family quiet communities where there's 2 cars in every driveway.
Yeah. It may seem that way from the perspective of 2024, but the way those zones came about was a victory of progressive politicians of the past who were battling developers who did exactly the opposite of what you're talking about. They would find spots to downzone so they could build things that would make them more money. And that's one of the main ways people used to make money in Anchorage is they would go to the assembly, use their influence, get something downzoned, then be able to sell it for a profit and have an inappropriate use that it harms the quality of life of the people who live around it. The Anchorage 2020 plan was a true grassroots community plan driven by progressives. And the idea behind it was, let's make public transit work in Anchorage by developing community centers where you'll have higher density housing. And so people will be able to use public transit and have the kinds of facilities that we have in more urban parts of the country that really work and build community. And if people want to live in this broadly dispersed single family housing in other areas, they can, but they're not going to have those amenities. And that was part of the concept behind it, the new urbanism concept. And what they ended up in the final bill was just adding some more auxiliary dwelling units and duplexes and stuff. And that's not a big deal, right? But the original bill was pretty radical. And it would have really swept away decades of work by progressives who had really good reasons for what they were doing, whose enemies were these profit-hungry developers who were just rip and run and made Anchorage in many ways such an ugly city.
I want to move on, and I'll say an interesting phenomenon about you as a writer is that you have co-written so many books with other folks. I interviewed Vic Fischer twice for the podcast. We used the book that you co-wrote with him, To Russia with Love. And I'm wondering if you can talk about how you ended up being a co-writer with so many folks, and specifically talk about the experience of writing To Russia with Love.
Yeah, it's an interesting and rewarding job. It's also a way to make your living as an author of books, which is a pretty hard way to go economically, because the first one I did was actually in the 90s when I was still in the Assembly. I did a book with Governor Walter Hickel, and which was more of a ghostwritten book. So I've done sort of ghostwritten books where my name is not on the cover. And then I've done as told to books like Vic's, which is a book from his point of view, but that I'm helping do the first draft. And then I've done actual co-authored books like the one on COVID, where I worked with a scientist or a doctor and we're equal authors. The book with Vic was a total joy. It took a very long time, just something like 130 interviews and a lot of research. His 99-year life was just filled with letters and books and documents. And so just an extraordinarily rich record, which allowed us to put together just a story that's novelistic and sort of utterly three-dimensional, as you have all these characters weaving in and out through pretty much the whole of the 20th century in all these different settings. And we became extraordinarily close and shared just a lot of stuff. And it was a total pleasure. Vic was one of the most kind and loving people I've ever known. And he had such a commitment to humanity, and that his entire life was about creating systems that were going to be humane and would exalt the best qualities of people. And so a real model for all of us, really, about how we should live.
You've given 3 examples where you ghostwrite a book, where you do an as told to, and where you co-write. And I'm just curious because I feel like most people, when they set out to be a writer, they're thinking about doing their own independent projects. How are these projects presented to you? Do you seek them out, or do people come to you because you've gotten a reputation as somebody who collaborates?
For the most part, people come to me because it's hard for me to find people who want to write books. You can't really cold call. I do keep a presence out there. I have a literary agent who brings me clients. I did a book with Congressman Joe Neguse, who is now the second in command to Joaquin Jeffries in the House. And that came to me through a publisher and my literary agent, where I assisted him as a collaborator. In most cases, people are aware I do this kind of work and they approach me. And then, of course, I do my own work where I just come up with a book idea and sell it through my agent to a publisher. Dr. David Nash, who's the co-author on the COVID book, was someone who I met at a conference. I was actually moderating a panel that he was on. And afterwards, he said, "I'd like to talk to you." And we actually talked for a couple of years before we did the book. So it's a big commitment to do a book with someone. And you really develop a relationship before you're doing it, and then usually a very close relationship while you're doing it.
You clearly had a big interest in healthcare, and specifically in Alaska healthcare, prior to doing that panel with Dr. David Nash. I read your 18 columns from 2016 to 2017 that were specifically about problems in the Alaska healthcare system. Really great series. In fact, that's when I initially contacted you. I said I wanted to discuss those articles. The one that I think really sets the tone for how I read the COVID book was your article from December 28th, 2016, called How to Transform Alaska's Healthcare System into Something We Can Afford. I'll start just with one quote that really, I feel, sets the tone for what we have a problem with in Alaska. And it says, "We pay too much for care. Providers and hospitals as a whole cost too much. That's the key differential from the other states." And what I'll say, as somebody who's done 8 interviews about the cost of healthcare, who has read a lot of books about it, is I feel that you're really touching a third rail that people don't want to touch, which is the pay specifically that doctors get. And I think it's really important, and I think you do a good job of talking about it in the book, is that when we talk about doctor pay being too high, we're definitely not talking about primary care. We're definitely not talking about pediatricians. We're not talking about geriatrics. We're talking about specialists who, in Alaska in particular, create monopoly-like systems in which they set the price and the insurance company must pay because folks can't go anywhere else.
Yeah, it's a super important distinction. And even when I was writing those articles, I would have those primary care physicians coming to me and saying, "What are you talking about?" And in fact, my current wife did financial aid for schools, and she would have families with 2 doctors who needed financial aid for their kids because, especially outside of Alaska, the salaries are just middle-class salaries. The thing you just mentioned is very important in Alaska, which is the specialists. The other thing is Alaska doctors who own ancillary facilities. So they own a surgery center or they own the cardiac care practice. Their salaries are only partially from their own practice. It's also because of the profits from that center. And the facility fees are high. And then I remember having an injury from skiing and going to see an orthopedist in Anchorage and seeing a physician's assistant who said, okay, yeah, we'll schedule your surgery. Very cursory, didn't see the doctor. And then seeing on my medical bill, it's this fabulous fee, which I know the physician's assistant wasn't getting, right? So the practice was getting it, and then that's divided among the physicians. So when I was working on this, I actually, at one point, I went through the names of the doctor partners at one of the large cardiac care practices. And then I went down to the courthouse and looked for divorce proceedings involving any of them, knowing that their salaries and the income would be revealed there. I had to find one who was making like $2.5 million a year, which is ridiculous, right? There's no reason a doctor should make $2.5 million a year. And then people said, oh, that's just exceptional. And then Dr. Al Gross came out and did his article where he said, no, I'm an orthopedist. When I owned my practice and the ancillary stuff, I worked 2 or 3 days a week and I made more than $2 million a year. So that there's no way people can be taking that much money out of the system in the system functioning. And the fact that it doesn't is given by the extraordinarily higher costs that we have in our private system in Alaska. That's the other argument here from hospitals and from the people who own these facilities is, well, the cost of living is higher in Anchorage. Compared to actually Seattle, it's not higher. But if you look at urban areas on the West Coast, Anchorage is very reasonable. They're not paying their staff that much more. They're not paying that much more for rent, but they're charging multiple times more. So none of those arguments make sense. And that's what I was trying to say in that article is if we could get Alaska to just have the same medical inflation as the rest of the country, that would be a huge win. So you don't have to worry about all the problems of the rest of the country. Just figure out the Alaska problems.
I do have to disclose that I am a physician assistant. That is my job outside the legislature. I moved to Anchorage to work at the Alaska VA in 2016, 2017, around the time you were running these articles. And one of the reasons we left Santa Cruz is we could not afford to live there. So when people talk about the high cost of living in Anchorage, there are many cities on the West Coast where Anchorage is a much more affordable option. That argument does not hold water. Yes, it's more expensive to live in Quinnahock. It's more expensive to live in the bush, but Anchorage is not the bush.
And nobody's paying for private healthcare in those communities.
Speaking of Alaska Native care, you wrote about examples of care happening in Alaska that is analogous to an HMO style system in which you have a managed care system, a vertically integrated system in which the payers of the service are also the providers of the service. And I don't know if you can talk about just a bit about that particular issue before we get to the book, but specifically in Alaska, of having models that if we could extend to the whole population would make a big difference.
Yeah, and this has certainly been true in the rest of the country, and it has many different forms. It makes sense that if the payer is also the provider, that they'll avoid doing things the expensive way. So the way our system works now is that if you're a traditional fee-for-service provider, a doctor at Providence Hospital or something, you make more money if people are sicker. And if you make a mistake and you have to do another procedure, you make even more money. So quality doesn't pay either. Whereas if you're in a sort of a capitated system, which is what we call a system that's closed, like South Central Foundation, you take in money and then you save it by keeping people healthy so they don't have to go to the doctor. So you can do all kinds of things outside of the medical setting that are much less expensive, nutritionally counseling, making sure people are physically fit, intervening in childhood to make sure that they have healthy practices and they have a safe home. Some of these managed care they're doing through Medicaid, which has some problems, but also works. Well, they'll go into the elder's apartment and make sure there's not places where they can slip and fall. So by doing that, which costs you like a minimal amount of money to have a nurse go and do that, you then save how many hundreds of thousands of dollars of an orthopedist doing a hip surgery after the person has fallen. So that's the basic and obvious logic to it, is bringing folks into a situation where the financial incentive is for health rather than having the financial incentive be for sickness.
One thing that you wrote of specifically that would need to happen in order for us to move in that direction is to repeal a 1998 poison pill law passed by the Alaska legislature. Essentially, that law said that any managed care organization would have to allow its members to see any doctor they choose, which of course destroys the basic tenet of the managed care organization.
So this is something that, especially back in the 80s and 90s, people really objected to about managed care. And it was brought on in a heavy-handed way when it first started. And in fact, there were like Hollywood movies that were attacking it. And so
you did. You talked about it in the book. You talked about the movie with Jack Nicholson and Helen Hunt.
Right.
Where she did the gets.
Yeah, and her child can't get good health care because she's in an HMO, and so he comes in and pays for everything. And the problem is, it sounds nice to choose your own doctor, but as soon as you disconnect these parts of the health system, and the health system ranges all the way from the grocery store and the gym that you go to through the ICU, disconnect those pieces and start paying for them a la carte. That's where you get all these distortions. From the point of view, we were just talking about doctors making a lot of money. They also can make so much money in a managed care organization because the point of the organization is to reduce the amount of healthcare that's provided because it keeps people healthy if it's working correctly. Another way of thinking about it is the way we have set up the fee-for-service system, which is the dominant system in Alaska, is that our main cost control is the insurance company. Everybody hates the insurance company, but really when they're denying care or saying you have to pre-authorize, those are all ways of holding down cost. They're trying to prevent people from getting unnecessary care or get care that's overpriced. So they're an ally of keeping down the cost. It feels more like they're a denier of care. And obviously doctors don't like it because they're on the receiving end of that and they feel like they should get to make their own decisions. So you create an enemy between the payer and the provider. They're in this constant war, which produces a huge amount of wasted effort on both sides and massive amounts of administrative costs. So what if you say, no, the doctor works for the insurance company? That's his employer. So now he's not trying to game the system to get more. He's not charging these super inflated rates so that he can get it cut down by 50%. He's just doing his job. And his job is keep this subscriber healthy. Do it the least expensive way. So that means you have to provide him with groceries so he has healthy food and doesn't get diabetes. And that's the best way to do it. It's just something that makes more sense. And I think that, I don't know why that law passed in 1998, but I assume it was because doctors viewed it as a threat to their income.
An interesting observation I'll share. When I worked at an emergency department outside of Sacramento, Kaiser Permanente had a hospital in that same community. And working in the private emergency department where I worked, there was enormous amount of pressure for me to see as many patients as possible in a 10-hour shift, to never stop, just push through, see extra patients, pick up more patients. And we would have these monthly staff meetings with the doctors and the PAs where they would show on a chart what your productivity was and basically shame folks who had not seen as many patients. Interestingly, one of my friends who was a PA there went to work for Kaiser, and they had a limit to how many patients she could see in a given shift. I never understood that until right now. I was like, that's so weird. Why would they say that she could only see this number of patients? And I think the purpose was, it's really a change in the value of what's happening there. There was more value in her taking her time and doing a really good job with each patient than rushing through and charging for as many visits as possible. And who cares if that patient comes back 2 days later? Great, another charge. Yeah, right. Whereas when in a closed system, you want to do a good job so that patient actually doesn't come back 2 days later with the exact same problem.
Right. And so Kaiser Permanente was obviously the classic and first of these closed or capitated systems. And one of the really interesting things about it is customer satisfaction ratings are extraordinarily high compared to other insurance companies and providers. And employee satisfaction is rated very high, even though the salaries are not what they are. in some of the private system, and certainly for partners who own a system would make much more money. But the doctor's very happy there because they're not on a treadmill. They see as many patients as possible. They get their salary and they know that this person in front of me, his health is my priority. However we accomplish that, and looking at the person holistically, at the social determinants of health, where they live, all the preventive stuff, it's much more satisfying to do that, because that's why people go into healthcare in the first place, is because they care about people and they want to get them healthy.
In that series of articles that you wrote, there was discussion about a legislative task force. It was looking at starting a healthcare authority. There were some hearings. I don't know anything about their findings. I don't know anything about that healthcare authority that was considered. Can you just give me any information about what Alaska was thinking at that time? And
there were several things that were done, that were started, and we're now going back 5 or 6 years, so I don't remember all the details. I guess I would say that being in these meetings where there are summit meetings and everybody's being convened and they're coffee and Danish, and then we have some speeches from important people. There's 50 people in the room, and then you go into breakout groups and put things on sticky notes. You know after an hour that nothing's going to happen, right?
Right.
This is one of the problems, and I think it's partly because of this kind of small ecosystem in Alaska. There's a lack of public policy development. Ideally, in a larger state, you would have a university department somewhere that would be studying this and be like coming up with ideal solutions, and you wouldn't be counting on citizen legislators going out and doing all the reading themselves. And Ralph Townsend at ICER was doing that for a while. And he's no longer at ICER. Hussein Kutabi had done some of that work. He's now left the state.
He left. Let's go to the book. So you talked about meeting Dr. David Nash at this panel discussion. I assume that was a couple of years before you decided to collaborate on a book. You also made the decision to write a book about COVID while COVID was still happening. In the book, you talk a little bit about how immediately following World War II, the last thing people wanted to talk about was World War II. So it was an interesting choice to write a book about COVID. I believe you finished writing the book as Omicron was hitting. You'd gone through the Delta wave, but there was still a lot of COVID left to go when you guys submitted that manuscript.
Yep.
Talk about that choice.
We originally had already been developing the book before COVID became evident. We don't know exactly when COVID was circulating. And we wanted to write a book about population health. And Dr. Nash is kind of a founder of that field. He was the founding dean of the College of Population Health at Jefferson University in Philadelphia, and has had a long and very illustrious career. I was very honored to get to work with him.
And I think he's published a book called Population Health.
Yeah, he published the main textbook on the subject. Yeah. And population health, for those who don't know, and I didn't know either, is healthcare systems, looking at healthcare from the point of view of a systemic societal point of view. So it includes public health as well as clinical healthcare and everything else. And it's really figuring out what produces the health of the population, and breaking that down includes social determinants of health, clinical care, everything else. And so there's a series of lessons, including healthcare quality, that came out of that work. And I was learning all about it. He was also a pioneer in the area of medical errors and preventing them and investigating them.
The third most common cause of death in America.
Yeah.
As you point out twice in the book.
Yeah. Now fourth because of COVID. But so we had thought out this book, then COVID hit, and we said, I guess we're not writing a book. And then it just came to me one day, wait a minute, everything that we're learning from COVID is underlining something that we learned about population health. And we were already talking about healthcare equity. That was a main theme. Nobody was talking about that. Suddenly COVID realized healthcare equity is the name of the game. And cultural impacts and social determinants and payment systems, all of those things suddenly became super important. And so it seemed not only is COVID the biggest thing happening in the world, but it's also an incredible lens for looking at this topic. And then we wrote our proposal the fall of 2020. So we were in thick of it. Because at that time, we didn't know how long it was going to go on. We weren't like in a rush to do it, but we knew like this is a very important thing and this is our time. So we did it. Now, there were no COVID books that were really super successful. There were a few that kind of broke through, but in terms of a book just about COVID. If it will be written, it'll be written in the future. It's like
Right.
the first books about World War II didn't come out until 10 or 20 years later, when people really had gotten over it a little bit.
Two observations. Number one, I think that it definitely gave a wonderful framework for you to tell the story of the problems in American healthcare, because you were watching those different aspects of the system fail in real time. So I think it was a really great concrete example that everyone who's lived through that, which is most people alive today, could see what was actually happening. The second observation is that I think that in a way, by having the name of the book be How COVID Crashed the System, and people really not wanting to think about COVID, that it would probably drive some readers away from it, thinking, I don't want to read a book about COVID. I want to forget about COVID. And it's a bummer, because COVID is just the background. The real topic is the American healthcare system.
Yeah, I think that's true. I also think COVID is one of the biggest things that'll happen in our lifetime. And unless there's another pandemic, it's even worse, which is very possible.
I was going to say the disinformation started towards the end of Trump's first administration, basically saying that COVID was not as big a deal as it was. And you guys wrote in the book about some mistakes that the CDC made, actually specifically talking about Anthony Fauci saying that masks were not recommended, and then reversing course, that there were decisions made that caused the public to rightfully discount the public health information coming from our formerly most respected institutions. And then you couple that with the disinformation coming from the president, that it's not that big of a deal, we need to open everything back up, forget about these things, that it was a perfect storm for things to go downhill fast. And from doing this series of interviews that I've just done, I did an interview with a doctor from Texas who is a public health expert, and he kept talking about how poorly America had done during COVID compared to other countries. I believe most Americans do not know that's true. I believe that most Americans think that the way we did during COVID was pretty inevitable, and that we did the best we could, and that we couldn't have done better.
Yeah. When the truth is that we did the worst of any industrialized country, and that we had developed the strategies which were successful in other countries and were exported, and then we threw away those strategies and didn't follow them. I would also stress that we did very differentially well across the country. After the first wave of disinformation and politicization, which happened really in the early summer of 2020, and then definitely into the fall of 2020, COVID became a red state catastrophe. And if you look at the stats of the first part of it, it hit the East and West Coast cities first. And so that's where most of the mortality took place. But then if over the totality of the pandemic, especially in the second half, vast higher mortality in counties that voted for President Trump in the 2016, 2020 elections. And to a degree where multiple times more deaths, because this idea had been sold that masks don't work, that all the other things that we do to avoid the disease don't work, that vaccines are harmful. And so places where you had a lot of Trump voters, you had a lot of deaths. And places where people were more liable to respect the public health authorities, you had people surviving. And then in a way that's, to me, very similar to January 6th, where people say, oh, it wasn't really that big a deal. The place where this catastrophic death took place, well over 1 million people, we're up to 1.5 million Americans died, most of them red state people who didn't want to follow those rules. Then you say that's not a big deal because it was a horrendous failure. Let's put it where it belongs. It was a Republican Party, Donald Trump failure that killed many hundreds of thousands of their followers. And that's just the fact, right? So no wonder they want to say it's not a big deal.
The level of cognitive dissonance is quite high. I interviewed a Wasilla legislator for the podcast, and he said that he was quite proud of how Wasilla had remained open during the pandemic. I pushed back on that. I worked at the Wasilla VA for a while, and I said, look, the COVID complications that I saw in Wasilla were much worse than Anchorage. And that same legislator who just said how proud he was of how open Wasilla was, said that that one of his own employees had died, who was like 50 years old, overweight, probably not in the best shape, but died at age 50 of COVID. So on the one hand is, oh yeah, it was terrible. One of my employees died. On the other hand, saying, but you know what? It was bound to happen. You wrote a little bit about it in the book about those assembly meetings happening in Anchorage where people yelling and screaming that the tyrannical assembly is shutting things down. People who were standing there screaming died. They died of COVID. And
like a week later. Yeah.
Yes. And yet there was no connection that being in a crowded space without masks that close to each other was a super spreader event.
No, and I think that goes to another issue, which is the loss of media and media gatekeepers and the failure of the new politically divided media to actually tell the truth to people. They don't know that information. So yeah, it is quite sad.
A phenomenon over the last 100 years of us really focusing on this fee-for-service model of medical care has made public health even more looked down upon than it should be. Do you have that quote?
Page 14. Yeah. Public health interventions are humankind's most effective lifesavers, adding far more years to Americans' longevity than medical care and for a small fraction of the cost.
And I think COVID was a perfect example where we had public health giving these directives that would have saved hundreds of thousands of lives, but it was just lost.
Yeah, and you had Fox News, Tucker Carlson doing a whole series about how you shouldn't do prevention, you should do treatment. And then, ivermectin is a thing, or hydrochloroquine, or these quack ideas that didn't work. We didn't have really good treatments. And the only way to get out of a viral thing is through prevention in the long run and through immunity. Yeah, it's very sad. And we're still in COVID. There's still a lot of people getting it. And something like 1 million people are still missing work because of long COVID, and more people are getting long COVID and still affecting people's IQ. So it's not exactly like it's gone away. It's just that we don't want to hear about it anymore.
I think that ties into a phenomenon in American culture specific to our healthcare system, which I've seen as a medical provider. I have had diabetic patients who, when I've asked about their diet, said, I had some donuts this morning for breakfast, but that's okay. I took some extra insulin. And this sort of model within the system itself, perversely incentivized, that you don't have to do the hard work of controlling your diet, getting more exercise. You can just take some extra medicine and then you can do whatever you want. That our phenomenal healthcare system will rescue you from these behaviors. And I think the same thing that you were talking about with Tucker Carlson. Don't worry, go to the movies, do whatever you want. Just take some ivermectin, you'll be fine. Unfortunately, ivermectin didn't work.
Right.
But I think it speaks to this issue that medicine is more important than prevention and public health.
I think that's true. I think that's because we live in that weird bubble of misinformation about the value of technology and of clinical medicine. The people thought that America wouldn't be severely affected by COVID. And then when we were, they thought we hadn't been because, after all, we have all this technology and we spend so much money on it. But if you just look at the stats that other countries that spend way less, not only did better in COVID, but they do better all the time. They have better prevention, and then they have better life expectancy and better health during life than the United States does. And in fact, the healthiest people in our country who have the best access to healthcare are still worse than the average person in these other countries that have universal health care and spend much, much less. So the healthcare interventions are not very effective in extending life and in expanding the quality of life.
I'd like for you to read this quote.
Sure. This fact supports Dr. Martin Luther King's statement in a letter from Birmingham jail. Injustice anywhere is a threat to justice everywhere. We are caught in an inescapable network of mutuality, tied in a single garment of destiny. Whatever affects one directly affects all indirectly. Indeed, research from the World Bank shows that nations with greater income inequality tend to have lower overall life expectancy.
Right. a very common sentiment that I hear in Alaska today, I guess in our country today. Elon Musk, just before this interview, I saw that Elon Musk posted quite a long excerpt of an interview with Milton Friedman, in which he talked about all the different departments of government that can be eliminated. They are departments that work on reducing income inequality, ensuring that everyone has adequate housing, ensuring that everyone has access to a good education, eliminating those departments, because to his mind, they were government waste. But I think what we see here is that's very short-sighted. And that although you may think, rich white man, that you are going to escape these negative outcomes, you're not. We know that rich white people in America do not do as well as the average in some of the countries that have less income inequality.
Yeah, that kind of libertarianism always reminds me of the libertarians in the jungle. The tigers are the libertarians, right? Let's take away the rights from the prey. And I think that's what you're hearing from somebody like Elon Musk. Just to be brutally honest with residents of Anchorage, you're living under this government that doesn't tax and doesn't provide services. And when you drive down the street, people all over the street, people die in doorways, freeze to death. You have like violent crime, you have an awful drug problem. How is that better? Wouldn't you rather pay a little bit of tax to live in a place where you have a quality of life for everyone that affects your quality of life too? And in the healthcare field, it actually turns into having a healthcare system that promotes health rather than promoting fees for healthcare systems is beneficial to all. So, as you say.
Speaking of housing and homelessness, I'd like for you to read this quote from page 250, which is basically spelling out the way we spent our money in the past, the way we spend our money now, and just how much could be done if we change the way we spend our money.
So this is again from How COVID Crashed the System. In America's past, its biggest and most world-changing technical efforts, the Manhattan Project to build the atomic bomb or the Apollo program to put humans on the moon, each consumed at peak 0.4% of U.S. gross domestic product. In 2020, healthcare costs 49 times more in GDP terms, consuming 19.7% of all our output. Would addressing our nation's housing problems be too expensive as a way to improve health? We already spend more on healthcare than every dollar allocated to housing every American.
Yeah, it's insane. Like that number, the amount that we spend on housing, and I assume you mean like mortgage payments, rents, all of it.
At Elon Musk's house and somebody who lives in Brother Francis Shelter, everybody combined, still less than healthcare.
Yeah. And we know that, as you talk about so much in the book so well, the social determinants of health, people who can't afford housing have terrible health. And when they go to the emergency department in our current system, expensive tests, CT scans, I don't have the numbers in front of me, but as somebody who's worked in an emergency department, if a drunk, passed out person is brought into the ER, we do a CT scan of their brain to make sure that they're not unconscious because of a brain injury. And if they get brought in 5 times in 1 week, we do that CT scan 5 times. It's several $1,000s every time we do it. And people say, oh, who's paying? We are.
Right. Instead of paying taxes to take care of that person through some kind of organization where it maybe costs like $25 a night to house him, you pay it through your healthcare premiums, and a huge proportion of your compensation goes to healthcare premiums, and also through your federal taxes to Medicaid, which is also going to cover that person far more than if you just gave him a home and a caseworker to take care of him.
Right. And I had the lead pastor from what was formerly Anchorage Baptist Temple, which is now Mountain City Church, on the podcast just a couple of weeks ago. And he says in one part, I'll paraphrase, that the price of alcoholism may be starvation, and we need to allow that by providing food, not housing, but providing food to somebody who is drunk all the time is actually enabling them to stay drunk all the time and not work and earn. The short-sightedness of that that we're not going to provide anything to this person because it's going to waste money it can't be exaggerated. The amount of cost savings and housing that person, providing them with adequate nutrition, getting them access to the healthcare that they need, those three things are going to improve their chances of achieving sobriety or drinking less. They're not going to do it while they are homeless in Anchorage when it's 0 degrees outside as it is today.
Right. And the scale, people don't really have a sense of the scale of dollars for these things, that how inexpensive these social services are in terms of food banks and giving people rooms compared to the other things we spend money on, especially healthcare being the best example. During the pandemic, we had something like $4 trillion in excess spending for all these programs that we did. And less than 10% of that was for income support. The people actually lost wages because they tended to be at the lower end of the income spectrum, and they were folks who had frontline jobs, which are mostly working class people. Their wages are so small that insignificant. Honestly, you could have paid for that without any hardship. Of course, politically, in order to do that kind of crisis thing in our country, you have to give money to people who don't need it as well. And we gave away $4 or $5 billion. It caused all this inflation. But in terms of how many people actually needed it, taking care of those poor people is really cheap.
Systemic racism really is an enormous part of the book. You talk extensively about how much worse predominantly Black communities, in particular on the East Coast, did during COVID for many reasons. One of the most shocking things was when you guys quoted W.B. Du Bois talking about his research in Philadelphia 120 years ago and the disparities in healthcare and access to healthcare, and flash forwarding 120 years and nothing has changed. Yeah. The story you told about Dr. Stanford, the Black physician who had gone into these neighborhoods to do intervention because the folks there did not have access and were distrustful of the medical system within Philadelphia, I found particularly memorable.
Sure. Yeah. Dr. Ada Stanford was a African-American physician. She'd actually become a concierge physician, a high-level doc. And then when COVID hit, the stats were showing very clearly that testing was not taking place in African-American neighborhoods, which had the highest risk because people living in close quarters, people who were not able to stay home from work, you can't do these jobs as a delivery person via Zoom, right? You've got to be out there doing it. And no one's serving them. And so she got supplies. She went to the hospital. She went wherever she could go to get supplies, grabbed some of her colleagues, threw it all in a minivan, and drove out and parked on the corner and started a clinic. And just huge lines of people came to get tested and then to get other primary care. So she would be out there and somebody would say that there's something wrong with my shoulder. And she'd say, I brought this orthopedist along with me. And so she started taking care of people on the street. And this exploded and became an ad hoc thing in the neighborhoods of Philadelphia, providing folks with care who needed it. And the irony of it, as we know in the book, is this is a city with 4 major medical schools. And just the idea that it takes somebody to do that, to provide care where it's most needed, is such a sign of our failure.
How they rewarded her was also just so incredibly, shockingly bad. If you could talk about them renaming the street and doing it on camera.
Yeah, I think it was ABC, like Good Morning America, because she was made all kinds of media because she was a hero, a COVID hero. We're all looking for these happy stories. They came in to reward her and say, you're so incredible. We're going to do a segment live on national TV. And then they presented her with a street sign. They said, we're changing the name of the street in this neighborhood to Dr. Ada Stanford Boulevard. And she starts to cry. She's overwhelmed. You know, such an honor.
And I would say the reporter said, this is an actual street sign, and it is actually going up in this neighborhood. That was what he said on the air,
right,
airing nationally.
And the whole thing was a fraud.
It was fake.
They'd never gone through, there's a long process, as there is in any town, to rename a street. Nobody even started that process. They just called up the mayor's office and had a sign made and handed it to her. That's all it was. And so the empty, fraudulent nature of it was, to me, so symbolic of the whole thing, right? We're not actually going to do anything about this problem.
We're not actually going to help poor people in this neighborhood.
Right.
we're going to reward this person who did it all voluntarily. That's
Right.
off the clock. She's not getting paid to show
And she
up.
paid for the supplies. Yeah.
Yeah.
We're going to give, and then her reward is also fake. So it's just, yeah, it was extraordinary.
But I think I bring that up again because I think that philosophy of folks who are failing fail because they didn't work hard enough. And if you live in a poor part of town, you deserve to be there because you didn't work hard enough. And if you worked as hard as me, then you would live in the nice part of town and you'd have good health insurance and you'd have a doctor who would order the tests that you needed when you needed them. And it seems like that philosophy is going to be in charge for the next 4 years with the recent presidential election that is very alarming.
Yeah. Yeah. Something has happened to where even the coalitions that should be voting for their own self-interest aren't doing so at this point. So or at least to the extent they should be. No, it's really true. And we talked earlier about education. We used Philadelphia as a microcosm because of Du Bois's writings and also because that's where Dr. Nash's hospital is. And one of the things that was mind-blowing to me is that when a mile from Center City, Philly to West Philly, there's a 15-year difference in life expectancy. The people in Center City all went to private school. They're all white. The people in West Philly go to the public schools in Philadelphia. If you look at the achievement numbers in those schools, the vast majority of kids don't gain basic skills by the time they graduate from the public schools. So at one time, it was a sort of a industrial town. It's not anymore. You have all the industry there is healthcare, finance, insurance, things where you have to have an education. So you produce this entire class of people who have no way to get a job in the economy that exists. So just a priori, it's like an endless cycle of poverty that there's no way out of for them. Then on top of that, because of the poverty in those communities, they don't have access to quality food, to exercise. They don't have shade. It's much hotter in those neighborhoods, so they have very high levels of heat stroke and problems from hot weather. High levels of crime. So a lot of people get killed in shootings, extraordinarily high levels of diabetes. So all of these things go together. It's a system that we created where those people live over there, and this is how their lives are. And it's very little way out of it. And every so often there'll be somebody like Ada Stanford, who is a superstar and finds her way out. So we think, oh, there's lots of upward mobility. Most people are not superstars. So if you or I were born there, we'd have the exact same outcome.
You write in the book about healthcare outcomes for babies and that Black babies treated by white physicians do worse than Black babies treated by Black physicians. And we don't have enough Black physicians. And really, there's been no change in the last 40 years.
Well, it's actually gotten worse. So at least among Black males, there are fewer per capita Black male physicians now than there were in 1970. If that statistic doesn't blow your mind, nothing will. In like 68, Blacks were allowed to be members of the American Medical Association. Prior to that, they were denied membership. Because of the failure of public education, we haven't been able to increase that population at all. The other thing, though, is that there's no reason why Black moms and babies should be treated worse by white physicians. That's just because of prejudice. And so that...
Dr. Nash talked about teaching at medical school and asking the medical students coming in from rotations, raise your hand if you've witnessed doctors saying something racist, and every hand goes up. Raise your hand if you believe care was impacted. Hands go up. Like they all are witnessing this. We see it happening, and yet the system continues exactly as it has before.
Yeah, yeah. And it's discouraging, very discouraging to see our country going in the wrong direction on these things.
I want to pivot in Alaska in particular. Telehealth has the potential to really be groundbreaking, really transform the way we do healthcare. But the attempt at expanding telehealth has been met with a lot of resistance. And I think here, I've got a quick quote from the book, pretty informative.
Yeah, telehealth visits normally cost as much as office visits, Hollander said, because doctors and nurses do the same work either way, and brick and mortar facilities still have to be paid for, even if they're not being used. He added that if telehealth becomes entrenched and payment is assured, providers probably could downsize facilities, perhaps saving 15%. Some studies have estimated savings of 30%.
I think in Alaska, the savings would be even greater because one of the huge costs is traveling to Anchorage to see your doctor. And if we eliminate those travel costs, then we are cutting a huge cost out of the system. It may not be borne by the insurance company. So in terms of where is that going to be felt? For some patients, it's going to be felt by the patient themselves. And maybe the system won't reward that and won't be interested in that. But it's certainly in the best interest of healthcare in Alaska to prioritize having people be seen in a timely fashion that doesn't involve this enormous expense of flying away from your home and spending the night somewhere else for a 30-minute doctor appointment.
Yeah, that's a good insight because there's something experts have pointed out is that this is the case of externalities. For the physician, having the person come in and sit in front of them in the doctor's office, it does a number of things. For the physician, it's no cost to him that the person had to take time off work, drive across town, wait in the waiting room, tell the nurse everything, tell him everything again, sit there, and then, reverse the process to go home. But having the person there gives him a greater power over the relationship. And one of the things about telehealth is it's a flattening thing. It puts more power in the hands of the patient, more ability to determine the place of care, the time of care, the information exchange, and the whole thing. And the first time I did a telehealth visit, I thought, oh my gosh, I never really want to do it any other way. For a 15-minute visit, I spend 15 minutes. And that's huge in most people's lives. And I'm not doing all this driving and everything else. Yeah, if facilities want a reason to cover their overhead, they don't necessarily want to save money because more money is more charges.
What was fascinating in the book is it talked about how urology was a place where a lot of folks preferred telehealth, and breast oncology, that men didn't mind showing their scrotum to the camera and women didn't mind showing their breasts. In fact, they preferred it to doing it in a strange office environment. They'd rather just do it from home and be like, hey doc, does this look right? Is this scar healing? That sort of thing. That blew my mind because I would have thought that like urology and breast oncology would not be the types of visits that would be conducive to telehealth.
And there are definitely some areas of medicine where you have to touch the person, and to do a proper breast exam, obviously would have to feel for lumps and so forth. But one of the things that may be easy for healthcare providers to forget is this sort of a loss of dignity that occurs in the examination room, especially when we have to put on these crazy gowns that are open in the back and have to sit there in the cold and wait a long time and the whole thing. That it's really the way that clinical thing is set up in a lot of settings, especially more traditional ones, is reducing the status of the patient and enhancing the status of the provider. And the patient doesn't necessarily like that. They might really prefer to be in their own home and controlling their own space and what they're doing with their body.
Hey, we're at the end of our time. There were so many things I wanted to talk about. I wanted to talk about Senator Daniel Patrick Moynihan of New York really tanking a lot of common sense reforms that the Clinton administration wanted to do, just the insanity of some of the things that he said on the record, which I think just shows that this has not been a red versus blue phenomenon. This has been a bipartisan effort to maintain an extremely broken system that has the rewards in the wrong place and is not in the best interest of our country's health.
Yeah, that's one of the flaws of our system is the ability of people who have a big financial interest to have an outweighted voice, right?
Can you talk about what your current project is or what you're currently working on?
I have a lot of things going on. I have a really exciting project, which has not yet been announced, but will be announced soon. And I'm thinking about writing a history of Alaska, which I'm very excited about. Many things happening.
Yeah, I won't say it on the record, but I think I know you have a book coming out.
Jump ahead when I'm working with someone. I can't jump ahead of their.
I know, but yeah, I'm looking forward to that one. Charles Wohlforth, thank you so much for being on the show today.
Thank you. I really enjoyed it.
I'm dropping links in the show notes to Charles's ADN op-ed about zoning, as well as former podcast guest Celeste Hodge-Groudon's response to Charles's op-ed. I'm also including a link to Charles's article series about healthcare in Alaska and a link to his website where you can find a full list of all his books. Thank you, listeners. If you like what you heard, please subscribe, rate, and review us. To contact me, email rep.andrew.gray@aklive.gov or call 907-269-0123.